Bismillahirrahmanirrahim. Respected seniors and dear colleagues, Assalamu alaikum and a very good morning. I'm Dr. Haider Nisar from AFBMTC Rawalpindi, and I formally welcome you in the fourth session of this elite forum. The topic of this session is Pediatric Hematology and Bone Marrow Transplant. This session would be chaired by Professor Dr. Tariq Ghafoor from AFBMTC Rawalpindi. Sir Tariq Ghafoor, sir, please, I would request you to please make it convenient to grace the stage, please. Now I would request my worthy panelists to please grace the stage. Dr. Nasir Bukhari from Children's Hospital, Lahore. Dr. Tariq Azam Khatak from AFBMTC Rawalpindi. Dr. Zehra Fadu from AKU Hospital, Karachi. Following panelists will be joining us virtually. Dr. Muhammad Ali from SickKids, Toronto. Dr. M. Usman Baig from Loma, Linda University, California. Dr. Sadaf Altaf from AKU Hospital, Karachi. And Dr. Saqib Ansari from Children's Hospital, Karachi. First speaker of the session, ladies and gentlemen, will be the chair of the session, Professor Dr. Tariq Ghafoor. Well, the professor, with his more than 20 years experience of treating various pediatric disorders, including both malignant and non-malignant disorders, immune deficiencies, and solid organ tumors. He's the current head of AFBMTC, current president of Pakistan Society of Pediatric Oncology, and an esteemed member of prestigious societies like International Society of Pediatric Oncology and EBMT. Professor will be enlightening us on the topic of how I sequence my treatment for pediatric ALL, LMIC approach. Sir Tariq, sir, please. Thank you very much.
So acute leukemia is the ALL is the malignant chronic disease of the bone marrow, and it is the most common type of cancer. About 50% of patients we see they are ALL, and if you talk about the leukemia, they make up the 75% of childhood leukemia is ALL. So basically there is the leukemic proliferation, accumulation and invasion of the normal tissue including liver, spleen, lymph node, as you know, and it can give the symptom within 4 to 6 weeks. With the bone marrow failure you get anemia, thrombocytopenia and leukopenia, and with the leukostasis, hyperviscosity, and with the tissue infiltration they get the organomegaly. And there can be joint pain, constitutional symptoms such as fever, weight loss, anorexia. So if you are going to make a diagnosis, the foremost important test is the blood complete picture with the peripheral smear, and then the bone marrow aspiration, and then the coagulation studies, chemistry, blood cultures, and chest radiography, especially in the TALL, and then the karyotyping, cytogenetics on the molecular genetics. CSF examination to document any CNS involvement. It can be CNS 1, 2, 3, depending upon the number of the blast cells. So coming to because I just want to highlight what are our problems. So this, as you know, these are these patients are risk stratified into according to their age. If the age is less than 1 year, they are treated as infant, and if on the infant protocol, if the age is between 1 and 10 years, this is a standard risk, and it is more than 10 years is high risk. WBC count at the time of diagnosis more than 50 is a high risk factor, and then ALL subtypes depending upon the immunophenotype. It can be TALL is high risk, then B lineage or mature B lineage, they are treated on lymphoma protocol, which is used for the Burkitt lymphoma. Then the cytogenetics. So standard risk, if you look at the the factors which place the patient in standard risk are age more than 1 and but less than 10 years, WBC count less than 50, without any high risk cytogenetics. Intermediate risk patients, they have TLL or age more than 10 years, WBC more than 50, and without any high risk cytogenetics. So high risk patients, they are who are slow early responders, then T lymphoblastic lymphoma, and high risk cytogenetics such as BCR-ABL, hypodiploidy, and MML gene rearrangement. So Pakistan Strategy of Pediatric Oncology, we have recently started with this uniform protocol for our centers in Pakistan. Most of the centers, they are following this protocol. So they consider some other factors for this risk stratification. Standard risk patients are same as age more than 1 year, less than 10 years, WBC count less than 50. There should be no testicular disease and no CNS disease, B cell phenotype, and good response to prednisolone, which are usually given for the 7 days, and on day 8 we assess with the presence of blast in the peripheral film, and there should be no high risk cytogenetics. And the other factors, they are high risk cytogenetics. So standard risk patients, they are treated on 3 drugs: dexamethasone, vincristine, pegasparaginase, and intrathecal methotrexate. And the intermediate and high risk, the induction therapy is the 4-drug therapy, which include addition of daunorubicin in the previously used 3 drugs. So then, depending upon the MRD, if the MRD setting is available or not available, if the patient is MRD negative, so continue with the standard risk consolidation, and if they are positive, then we give on the augmented BFN consolidation. And in the absence of MRD, then depend upon what is the marrow, is the M1, M2 or M3 marrow. So if it is marrow is M2 or M3, then we go on the augmented BFM consolidation, and then Capizzi, escalating Capizzi, or if it is again after post consolidation, it is M2, M3, the patient is taken off the protocol or go for the palliative care. So the main thing I want to highlight is the prognostic factors, and what are the prognostic factors in our setup. So I am going to present, this is my center study, which was basically done over 10 years experience of treating pediatric ALN in low and middle income countries. So all newly diagnosed patients with ALL or lymphoblastic lymphoma were included. Age was between 1 to 16 years. And 10 years data I already mentioned. They were started on treatment was standard arm of the UKLL 11 trial protocol, and risk stratification as I mentioned. There was 970 patients, and only 2.6% patient abandoned the treatment, which is different from the other centers in the Pakistan. This was mainly because we have very close follow-up. All those patients who try to abandon, we call them, and then sometimes we arrange them for the transportation charges and medicines, because you need to identify if you are going to manage these patients, then you need to take them along with, otherwise if you just start the treatment and then leave them, many of them they can't afford, then they will just leave the treatment. So data of almost 950 patients, including 600 male and 350 female. So mean age was about 5.7 years. And this is a very significant fact which I am going to highlight again. The mean time to reach the pediatric oncologist was almost 2 months. One patient reached to us after about 18 months of using various treatments. So most common presenting symptom was pallor, fever, and bleeding, bruising. Subtypes ALL, B-ALL was the commonest, about 82%, followed by TLL. About 5% patients, we could not classify them because there was flow cytometry, otherwise it was missing or it was inconclusive. So CNS disease was only less than 2%. Only 2 children, a male, they have testicular disease. Cytogenetics are available in about 60% patients, and majority of them, they were normal. So if you look at the risk group stratification, almost 50% patient in each group, regimen B 3 drug or regimen A 3 drug or the 4 drug regimen B. And the 80% of patients, they were less than 10 years of age. So major problems in the induction were neutropenic fever, myopathy, neuropathy, hepatotoxicity. And if you look at the end of induction marrow, it was almost 99% patient in the low risk group, they achieved remission, and it was 95% in the regimen B or high risk group. So overall survival was at 2 years was 75%, and at 5 years was 70%, and 10 years it was again almost 70%. So adverse prognostic factor which we identify with the high WBC count, intensive chemotherapy, and the malnutrition, poor response to induction chemotherapy, delayed presentation, and use of steroid before chemotherapy. These were all adverse prognostic factors. So two major causes of mortality was TRM, neutropenic sepsis, and bleeding. So in multivariate analysis, the children who got treatment, who took more than 6 months to reach to the pediatric oncologist, they were the worst group of the patients. So overall survival decreased from 70% to 51%. So there was 20% high mortality or decrease overall survival. High relapse rate, 10% increase in the children who started treatment more than 6 months after a diagnosis or the symptoms. There was high mortality, almost 20% increase as compared to the children reporting earlier. And steroid before starting induction chemotherapy, if you look at the overall survival decrease from 70% to 50%. So almost 20% decrease again. So please avoid treatment delay and steroid use in these children. Then we talk about the relapse. So about 16% patient relapsed. So again the risk group, standard risk, the relapse was 13% and it increased to 18.6%, 5% increase in the patient higher risk group. And again the age more than 10 years was associated with 10% increase in relapse as compared to the children younger than 10 years. And the male sex, there was 5% increase in male. And high WBC count, the higher the WBC count, the more the chances are relapse. It's starting from 13.8% to 23%. And poor response to induction therapy. So almost 100% patient relapsed who could not achieve remission at the end of the induction. So children initially diagnosed or misdiagnosed as ITP and JIA, juvenile rheumatoid arthritis, who used prednisolone 2 mg per kg once a day for more than 4 weeks. JIA is a bit tricky because I had a patient I mentioned who came to me after 18 months of treatment because initially was started on steroid, then methotrexate. So he took about methotrexate and ultimately, because as you know the methotrexate is a part of treatment of ALL, so his ALL was masked with the methotrexate and steroids, and ultimately he was treated as ALL. So relapse, if you look at there is 35% in the children who received steroids, and it was only 15% in the children who did not receive steroids. So please avoid treatment delay and the steroid use. This is just a graphic presentation of the same high WBC count is associated with decreased survival, and the standard risk patient, they have higher survival rate as compared to the high risk patients. So if you look at the other study, this is one of the just mentioned about the Cambodia. There's again the problem is almost same. If you look at their survival is event-free survival and overall survival is almost 1/3 of the patient they have event-free survival. Infection and bleeding are the major problems. So treatment outcome in children. This is one study from Egypt. If you look at the induction mortality about 23%. So what we are doing, what we can do to reduce this delay and unnecessary use of steroids. Pakistan basically joined hand with this global initiative of cancer care in developing countries, was WHO initiative. So Pakistan became part of this in 2022. And the objective is to increase capacity of countries to provide quality service for children with cancer and increase prioritization of childhood cancer at the global, regional and national levels. So Pakistan's strategy of pediatric oncology basically played a pivotal role in this. So we have made the protocol for these common 6 diseases including ALL, Burkitt lymphoma, that is uniform protocol is available in our country now. And these are the centers. If you start from the Karachi, there are, how many, there's 13 or 14 centers, they are doing collaborative studies. And this is the just a state of the data. We aim to get 1500 patients of ALL and we are nearly reaching them because this was the protocol started in April 21 and you can look at other protocols as well. So we're trying to teach the trainers. This is the early detection, this is basically series of workshop. This first one was done on 25th April this year, where 25 pediatricians from all over the country, they attended this workshop. And now they are planning to give these workshop in this month and the next month in all other 4 provinces. So thank you very much.
So thank you very much for sharing your valuable experience. Ladies and gentlemen, our second speaker would be Dr. Muhammad Ali from SickKids, Toronto, Canada. He will be joining us virtually. Dr. Ali has immense research work with special focus on stem cell transplant for metabolic disorders and use of immune therapy for mixed donor chimerism post stem cell transplant. Dr. Ali will be making us wise on stem cell transplant for metabolic disorders. So over to you, sir.
Thank you for your kind introduction. It's a pleasure for me to talk about transplant for metabolic disorders. So when we do allogeneic bone marrow transplant, we're essentially changing patients' bone marrow or hematopoietic system to a donor-driven hematopoietic system. And this type of treatment we routinely offer patients with high-risk leukemia, where the goal is to replace patient diseased bone marrow and also provide graft versus leukemia effect in an attempt to achieve a long-term remission for the patient's leukemia. And also we offer this treatment for patients with either missing bone marrow function, like in hemoglobinopathies, like sickle cell or thalassemia, and also in patients where there is either inherited or acquired aplastic anemia. However, in patients with metabolic diseases, the defect is not only in the bone marrow cells, the defect is in majority of these disorders is globally in every cell of the body. So the question comes how bone marrow transplant can help in such a disease or disorder. We'll talk about that. I have no financial disclosure. And the learning objective to describe role of transplant for metabolic disorders and also describe factors important for transplant outcome. So metabolic disorders are a diverse group of diseases arising from genetic defects, including deficiencies in the production of lysosomal enzymes and abnormalities of peroxisomal function resulting in progressive multisystemic diseases and an early mortality of the patient. If you focus on this diagram, there is a complex substrate in the middle, which when it's offered or presented to a normal cell, will be degraded into small and diffusible end products. While if this complex substrate is presented to a disease cell where there's a missing enzyme, this complex substrate is not metabolized, and instead it accumulates in the cell, causing changes in the cellular processes and inflammatory process initiated and causing tissue cell pathology and tissue damage, which may end up in causing death of the patient. So the treatment is simple because in majority of these disorders, there is a missing enzyme. So we can provide a source of enzyme in the form of injections. So there are many disorders where the injectable enzyme is now available. So you can provide this enzyme regularly to how to degrade these complex substrates, which is different in different types of disease. Or you can do a bone marrow transplant, where the bone marrow transplant, after achieving a good engraftment, will provide a permanent source of enzyme in the body. It's like a one-time treatment. Once it's successful, will be providing enzyme for permanently for the patient. So the common indication or standard indication of allogenic transplant in the metabolic diseases are these four. So Hurler syndrome, or mucopolysaccharidosis type 1, where there's a complete absence of the underlying enzyme. The cerebral form of adrenal leukodystrophy, where the brain is gradually inflamed and damaged because of the progression of disease in the brain. We'll talk about that later. And also metachromatic leukodystrophy, which is another lysosomal storage disease because of the missing enzyme. The brain and the nervous system is being damaged because of the missing enzyme and accumulation of the substrate. And Krabbe disease is another type of lysosomal storage disease causing neurological disorder. So in this pie chart, you can see it's a registry data from the Center for International Bone Marrow Registry, reported a while ago, showing common types of transplant reported to the registries. As we can see, Hurler syndrome is the commonest indication for transplant, 28%, 9% for a few other types of MPS, and adrenal leukodystrophy, like almost 20% of the patients receive transplant, followed by MLD and the globite cell, which is also called Krabbe disease. Osteopetrosis, another type of metabolic disease, but different from the other, the majority. 16% of those patients were reported receiving transplant. So this diagram helps to understand better in terms of difference between enzyme replacement therapy and stem cell transplantation. So in diseases where the enzyme replacement therapy is available, it's given intravenously regularly, almost every week. And this enzyme, through blood circulation, is able to reach to most of the organs, like liver, spleen, heart, and the tonsils. And those organs will get the benefit of this enzyme and will help to metabolize the accumulated substrate. And then if the enzyme is given regularly, they prevent further substrate accumulation and the organ damage. However, this enzyme molecule is quite big, cannot cross the blood-brain barrier. In diseases where the brain is also part of the disease, like in Hurler syndrome, unfortunately, this enzyme replacement therapy will not be able to prevent progression of disease in the brain. However, if you do bone marrow transplant, allogenic bone marrow transplant from a matched donor, non-carrier donor, once a patient achieves good engraftment, the monocytes coming out of the bone marrow, which is now bone marrow derived from the donor stem cells, will be able to travel and cross the blood-brain barrier and reach the brain and change into the microglial cells of the brain. So microglial cells of the brain are essentially hematopoietic in origin, and they are macrophages living in the brain. So once macrophages reaches the brain, they are able to deliver enzyme in the brain, which will be then available to, for the neurons and other cells of the brain to clear up the accumulated substrate. Then because this engraftment is permanent, so the enzyme will be available permanent for all brain cells. So this is the main difference between an enzyme replacement therapy and allogenic stem cell transplantation. So this is a little more elaboration of the stem cell transplantation and benefit to all organs. So once patient achieve good engraftment, the monocytes from the bone marrow can reach to the solid organs, as we just mentioned, the microglial cells of the brain. And we have resident macrophages in almost every organ of our body, like alveolar macrophages in the lungs, Kupffer cells in the liver, and the abdominal peritoneal macrophages. In the skin, we have Langerhans cells. In the bones, we have osteoclast. So I will mention briefly about osteoclast in the bone marrow and role of bone marrow transplant in osteoclast diseases, like in osteopetrosis. So infantile autosomal recessive osteopetrosis, where the defect is in the osteoclast, is treatable by allogenic bone marrow transplantation. It's different from the other types of metabolic diseases, so I'm not covering that in the subsequent slides. That's what I thought I'll briefly mention here. So when we plan for an allogeneic bone marrow transplantation for a disease that we think can be treated, so we need to formulate a conditioning regimen as well after selecting a donor. And inherently, when we have a disease like a metabolic disorder, the goal is to achieve a good donor chimerism as much as possible, because a good donor chimerism will be able to provide a good enzyme level for after engraftment, which will be helpful to reduce this accumulated substrate and also prevent further substrate accumulation in the body. Hence, the disease feature will improve over time. So because our goal is to achieve engraftment not only in the bone marrow, but also to replace those resident macrophages in different organs of the body, including the brain, we need to be mindful how to achieve that goal while we are planning for a transplant procedure. So in this animal model, the mice brain was exposed to 3 types of conditioning regimen: triosulfan, busulfan, and radiation. And then they looked into the short-term and long-term engraftment of donor monocytes, hence macrophages, in the recipient mice brain. The red is conditioning after busulfan, blue after radiation, and green after triosulfan. As we can see, the red bar is quite long, and both in the short term and the long term, while the green one is quite minimum, and the blue in between. So, which reflects that busulfan or any conditioning which can penetrate the brain will help a better microglial engraftment on donor macrophage engraftment in the brain to change into host macroglial cells, while triosulfan, which we know cannot penetrate the brain, will not help that much in terms of engraftment of the donor macrophages in the brain. So the first transplant for Hurler syndrome was reported back in 1981 by a transplant team in London, and first transplant was for cerebral ALD was reported back in 1990 by a group in Paris, France. And after that, many centers across the world started to offer allogenic transplant for a variety of metabolic diseases, as underlined here. So Hurler syndrome, infantile Krabbe disease, juvenile metachromatic leukodystrophy, mucopolysaccharidosis type 2, or Hunter syndrome, Wolman disease, Gaucher, and a few other types. So when we do bone marrow transplant for Hurler syndrome, there are certain things that over time we learned that will help in terms of transplant outcome. So one is stem cell source, and then the second is the age at transplant. So in this report, the patient who received a matched sibling donor transplant and or received a fully matched cord blood, they had the best outcome compared to patient who received a mismatched cord blood or a matched unrelated donor transplant. And patient who underwent transplant at a younger age, in this study, the cutoff age was 16.7 months. They had the better outcome compared to older patients. So hence, age is important, and also stem cell source is important when we are planning transplant for Hurler syndrome. Age is important because the older the patient is, their major organs like heart, lungs, and also the brain will likely be significantly impacted, and these patients will likely not tolerate transplant procedure the way we want, and they may end up having significant transplant-related toxicity and high rate of mortality. And age is also important in terms of neurocognitive outcome for patients with Hurler syndrome. So in this diagram, we see three curves, so the blue, the yellow, and the red. So the blue ones are the ones who receive transplant at a very young age, around like 4 months. The yellow around age 12 months, and the red around age 26 months. As we can see, the neurocognitive outcome for the younger patients, the age 4 months and 12 months, they had quite a normal neurocognitive outcome, quite similar to a normal child, while patients who receive transplant at the older age, their brain is already significantly damaged by the substrate accumulation, their neurocognitive outcome was not as good as the younger patients. So again, age at the time of transplant is very important. And when we do bone marrow transplant for these metabolic disorders, our goal is to provide a high enzyme level. And high enzyme level will correlate with the better metabolic correction. So in this report from the UK group, they looked into the enzyme level and the substrate clearance. And substrate clearance was measured in the form of mucopolysaccharide, like a dermatan sulfate and quantitative sulfate ratio in the urine. So as we can see, the higher the enzyme level, the lower is the substrate ratio, meaning better clearance. And also patient who received an unrelated transplant, meaning donor had a normal enzyme level. So they had much better substrate clearance compared to a patient who received transplant from a carrier donor or a patient who received only enzyme replacement. And also chimerism correlates well with the enzyme level as well. So the higher the enzyme, donor myeloid chimerism, the better will be enzyme level, hence the better will be metabolic correction. Patient who achieves mixed donor chimerism, if the chimerism is low, that will correlate with a lower enzyme level, which will then correlate with less optimal metabolic correction. So this is probably the only type of transplant, non-malignant transplant, where we intentionally give a good dose of myeloablative regimen in order to achieve a very good chimerism to provide a good enzyme level. The transplant over time has shown to alter the fatal course of Hurler syndrome, as shown in this diagram. A patient who received transplant, particularly in recent times, they had much better outcome. So almost 90% of these patients are now surviving with the help of transplant, while patients who did not receive transplant, they over time, unfortunately, often passed away. And because they are surviving longer, so they are anticipated to accumulate significant long-term burden of the disease. This is a report from the French group where they reported 25 patient long-term outcome of 25 patients. 24 out of 25 patients survived. The median age of transplant was 21 months. The range was 12 months to 57 months. And the length of the lines, the dark one and the light color basically shows the burden of the complication or late effects related to the disease and also requiring surgery. So as we can see, majority of these late effects are related to the bones and joints requiring surgical correction. Unfortunately, patients with Hurler syndrome, even after transplant, they will still develop bone-related complication, joint-related complication, because bones are very hard to reach areas even for the transplanted macrophages and monocytes. And switching gear now to cerebral ALD. So as we all know, adrenoleukodystrophy is X-linked metabolic disorder because of gene mutation in the ABCD1 gene, which is then causing basically in this condition, there's a missing ALD protein, which is in the membrane of the peroxisome in the cells. And this protein works as a transport channel for the very long chain fatty acid. So when this protein is missing, the very long chain fatty acid accumulates in the cell, which then causes inflammatory response or derangement in the cell, causing subsequently demyelinating condition in the affected brain, as shown in the MRI. We can see white matter changes in the MRI. And the important thing to note, when we are considering patient who's developing cerebral form of ALD, we need to do a contrast MRI to make sure before we consider them from transplant, this is a contrast enhancing lesion, because in 10 to 15% of patients with the cerebral form of ALD, these lesions may spontaneously arrest and patient may not need transplant. However, we will consider this patient to transplant because transplant is the only treatment. The patients who have the contrast enhancing lesion are they have the only treatment available for them is the allogenic bone marrow transplant in an attempt to halt the disease progression. And the transplant is considered only in the early stage of the cerebral ALD, because unfortunately the advanced stage of the disease will not benefit from transplant. Because when the patient has early stage of ALD affecting the brain, which is defined as either IQ score of 80 or higher, or in the MRI, the lesions are scored by a low score. So Dr. Lowe's was the radiologist who invented this scoring system back in 1980s. So the score is given from 0 to 35. So the low score, if it's 9 or less, is considered early stage disease, and score higher than 9 is considered advanced stage disease. So we will not offer transplant for a patient who has a low score of more than 9, because the disease pace is quite fast, and the benefit of transplant starts only 6 to 12 months after transplant. And during that time period, because of the inflammatory response during transplant, the brain disease will progress rapidly, and a year or 2 years after transplant, patient will eventually develop significant neurological deterioration, will not end up having this, will not benefit from transplant. So unfortunately, this is the only condition when the patient and parent comes to us. If the MRI shows advanced stage disease, we explain to the family, and then we say probably should not take this child to transplant, because we'll just lose the cherishable time that patient may have with family in the attempt to do this transplant, which would likely be futile. So when in this paper, the transplant outcome was compared for patients who received transplant in the early stage versus advanced stage. As we can see, the overall survival was much better when the transplant was done in the early stage of the disease compared to the advanced stage. And also patients who received transplant in the early stage, they had the major functional defect-free survival much better compared to patients with advanced disease. And the last few slides about the other two common indication for transplant. So MLD, again, another lysosomal storage disorder, where there's substrate accumulation in the central and peripheral nervous system, causing demyelination and resulting in profound intellectual and motor disability. So MLD is basically classified based on the age of onset of the disease into late infantile, juvenile, and adult. Late infantile disease, unfortunately, is rapidly progressive, and these patients are not considered candidates for transplant. While juvenile patients, usually for them, the disease progresses slowly, and then there will be a chance that transplant will benefit these patients. The same for adults. So in this paper, published from the 3 hospitals in Germany, we looked into the long-term benefit or outcome of transplant for patients with MLD. So there was no significant difference in terms of their overall survival. One, because this was the transplant era was from 1991 to 2012, and there were 17% transplant-related mortality because of high rates of infection. However, the clear benefit was for transplanted patient was into their better gross motor and cognitive function over time. And my last slide before summary slide, so transplant for patients with Krabbe disease, which is another type of lysosomal storage disorder because of enzymatic deficiency. And this condition is also just categorized based on the age of onset of symptoms into early infantile, late infantile, and juvenile. The early infantile and late infantile almost makes 85% of Krabbe disease cases, with 20% in the late infantile. So the transplant usually considered for patients who are diagnosed either asymptomatic or very minimally symptomatic, because again, the disease progresses quite fast, the patient is already symptomatic. So in this paper, the outcome of late infantile Krabbe disease was described. The transplanted patients were divided into 3 groups. If they were transplanted asymptomatic, or they were symptomatic, but the age was less than 12 months, and the symptomatic age was more than 12 months, and then there was a comparison group of patients who were not treated with transplant. Patients who received transplant when they were not symptomatic, they had the best outcome. All of them survived, and their neurocognitive outcome was very good, almost as good as like a normal children. However, patients who received transplant when they were symptomatic and more than 12 months, their outcome was less than the asymptomatic patient, but quite reasonable, and they also had reasonable neurocognitive outcome. Compared to patients who were symptomatic but less than 12 months, they had, unfortunately, a very bad outcome. So their neurocognitive outcome was quite similar to patients who were not treated with transplant. So again, suggests the impression is that we should take this patient to transplant only if they are asymptomatic or older with minimum symptoms. So this is my summary slide. So allogeneic transplant has largely contributed to the improved survival and quality of life of many children affected by metabolic disorders. Early diagnosis and transplant is critical for optimal results. For maximal engrafted survival rates, a non-carrier matched donor, meaning sibling better than fully matched cord blood or better than unrelated cord blood, unrelated donor, and a busulfan-based myeloablative conditioning regimen would be preferred to achieve full donor chimerism and a better enzyme level. Neonatal screening could enable earlier transplant to help reduce residual disease burden and improve overall outcome. A multidisciplinary approach is required for long-term management, given these patients are surviving longer and they have significant burden of underlying condition. Thank you very much.
Thank you very much, Dr. Ali, for such a thorough talk. So, ladies and gentlemen, our next speaker is Dr. Itriza Sheikh from MD Anderson, Texas, USA. He's a thorough professional and highly skilled BMT physician with a keen interest in use of immunotherapy for the treatment of hematological malignancies. His topic of discussion is stem cell transplant for immunodeficiencies.
Good morning, everyone. My name is Itriza Sheikh, and I'm currently a pediatric stem cell transplant physician here at MD Anderson Cancer Center in Houston, Texas. Thank you so much for the opportunity to present at this conference, where I'll be discussing indications for stem cell transplant in pediatric immunodeficiencies. It's a broad topic, and there's a lot of material to cover. So for the sake of time, I'll highlight three conditions: SCID, Wiskott-Aldrich, and chronic granulomatous disease. And you'll for sure see that a pattern emerges. So one of the most common immunodeficiencies across the world, including the United States and in Pakistan, is severe combined immunodeficiency, characterized by X-linked disorder due to a mutation in the IL-2RG gene. This renders T cells non-functional qualitatively as well as quantitatively, with the downstream impact being a loss of B cell function. And there are various mutations that, including JAK3, RAG1, RAG2, that really block this development of T cells and have this downstream deficiency in B cells as well. In the US, at least, SCID can be diagnosed via newborn screening through a heel pinprick shortly after birth. And the test looks for T cell receptor excision circles, also known as TREX, which are created when the T cell matures in the thymus. And so in those patients that have SCID, you don't have the development of T cells in the thymus, and so you have a deficiency of TREX. Now, there are other testing, including genetic testing, that can be performed, although those are less common. In terms of the presentation, these patients generally will present with frequent and severe infections, ranging from pneumonia, meningitis, sepsis due to these infections, as well as treatment-resistant thrush. Moreover, they will present with failure to thrive, and their fall from the growth curve or from the chart is usually very apparent. In this immunodeficiency, at least, oftentimes the best and only cure is going to be a stem cell transplant. And while matched sibling donors are preferred, there was a study published in 2014 in the New England Journal of Medicine where they looked at alternative sources, including matched unrelated donors, haploidentical donors, in some cases even umbilical cord donors. And what they found, there were comparable overall survival rates amongst other alternative donor sources outside of matched sibling or matched sibling transplants. Moreover, SCID is actually one of the few diseases where, based on the donor source, especially when you're looking at matched sibling donors, a conditioning regimen may not be needed. Moreover, they went on to compare a myeloablative or a MAC conditioning to a reduced intensity conditioning regimen, and they found that when you're looking at alternative sources that were not match-related transplants, again, they found overall survival rates were comparable between those two conditioning regimens, and that included transplant-related mortality and infections, again, being comparable between the two groups and those that were getting a MAC regimen or a reduced intensity conditioning regimen. And again, one thing that you'll notice is both of these conditioning regimens, similar to us in the United States, will include busulfan. We'll now turn our attention to the other part of the transplant, GVHD prophylaxis and related outcomes. So, like this publication described, here in the United States, we do favor calcineurin inhibitor-based regimens using either tacro or cyclosporin with the addition of either methotrexate or mycophenolate, also known as CellCept or MMF. Personally, I've always favored tacrolimus over cyclosporin due to the ease of dosing, following levels that are a bit more predictable when you do have to make the dosing adjustments, and just overall adjustments in the dosages are much easier, again, in my experience, when you compare it to cyclosporin. But when they looked at this study specifically, they did describe that in patients that were on adequate GVHD prophylaxis with a calcineurin inhibitor, severe graft versus host disease, which we define as either grade 3 or grade 4, was remarkably low at less than 10%. And there was a low rate of chronic graft versus host disease as well. And then to briefly touch on the outcomes, this is mainly to emphasize that patients, when they're transplanted younger, without active infection at the time of the transplant, they did absolutely great. And they will note that the age cutoff they used here was 3.5 months, which is a bit of an arbitrary value, so it shouldn't be taken as a hard, fast rule. But again, they saw that in patients that were less than 3.5 months and they were transplanted, they had significant overall survival rates. However, what we need to keep in mind is that when they looked at patients that were over 3.5 months, the 5-year overall survival rate was actually 82%, which in my opinion, is still remarkable in itself. I've touched on this in terms of donor sources, but just to emphasize, like many other transplantations, when you're looking at immunodeficiencies, when you're looking at heme conditions or even malignancies, a matched sibling donor transplant is generally preferred. They tend to do better when it comes to transplant-related mortality, when it comes to things like GVHD, both acute and chronic. However, again, in this, matched sibling donors did remarkably well with a overall survival rate of 97%, but the others didn't do terrible by any stretch of the imagination. Those that did not receive conditioning, and they did receive a T-cell depleted mismatch-related donor graft, again, they also did very well with a survival rate of 79%. And then in those that received a mismatched donor and underwent any type of conditioning, they tend to do a little worse at 66%. And then in those that received umbilical cord transplant, those generally did the worst at 58%. But again, the alternative, is much worse in terms of death and complications that come from SCID itself. So in summary, when it comes to SCID, there are excellent outcomes with children that have classical SCID who receive a transplant from matched sibling donors and they receive no conditioning regimen. Moreover, they had significantly better outcomes for children who received a transplantation in early infancy, which was defined as less than or equal to 3.5 months of age, compared to those that were older at greater than 3.5 months of age. But again, this is not a hard, fast rule. This is just something that they chose as a marker in this study, and they report on this. And the important thing to keep in mind is that alternative transplantation sources did have similar outcomes to those of recipients that received a graft from a matched sibling donor. Lastly, newborn screening for SCID, again, depending on the country, even at times depending on the state here in the United States, is important because it will help diagnose the condition earlier, which eventually will lead to early transplantation. That includes survival, that decreases transplant-related mortality, and overall leads to better outcomes, including graft versus host disease. I want to now turn my attention to what's called Aldrich. This is another condition where transplant is commonly employed. And the general presentation is what I like to remember with the acronym TIE. So these patients are going to present with thrombocytopenia, generally a microthrombocytopenia, immunodeficiency that leads to severe infections, and an overall eczematous body rash. And again, it can be difficult to discern, is this eczema versus purpura or manifestation thrombocytopenia, but generally it's a very rough rash. It can be raised. It's across the body, mainly on the trunks and extremities as well. However, similar to SCID, these patients are characterized by widespread infections, however less severe, but generally they'll present with frequent acute otitis media, frequent sinus infections, frequent pneumonia, and they're also susceptible to viruses such as CMV, such as Epstein-Barr viruses. They also generally will present with abscesses. And again, this is due to a defect in a whole host of their immune cells, including T cells, including B cells, and natural killer cells. Now, the diagnostic testing it generally relates to discovering the WASP gene, which is a protein needed for white blood cell motility and signaling. And like I mentioned, when you look at these patients in CBC, generally what you'll see is a microthrombocytopenia with a low mean platelet volume, or MPV, as well as low IgM. In terms of other immunoglobulins like IgG, IgA, those are very variable. There are some presentations where they may be normal, they may be low normal, or they can be very, very low. But again, the IgM is going to be your key. And then along with testing for the WASP gene, again, less commonly employed, you can also use flow cytometry testing to determine the amount of the protein expression itself. Again, similar to SCID, when it comes to a transplant for these patients, a matched sibling donor is what's preferred. And in this case, considering that these patients do have some baseline immune function, both qualitatively and quantitatively, a myeloablative conditioning regimen is preferred. And here in the United States at MD Anderson, as well as a lot of other publications, they do prefer a busulfan fludarabine regimen. However, there have been some cases where busulfan and cyclophosphamide have been used at myeloablative conditioning doses. And again, similar to SCID, GVHD prophylaxis with a calcineurin inhibitor-based regimen is what's preferred, paired with mycophenolate or methotrexate. There was a recent study published in 2022 where they compared BuFlu regimen with the addition of Thiatepa to BuFlu. And in fact, they found that just adding Thiatepa did not lead to any differences in overall survival, in GVHD-free, relapse-free survival, also known as Griffiths, or chimerism. They also compared triosulfan to busulfan-based conditioning and found that triosulfan was actually associated with an increased graft failure rate, mixed chimera, and a need for secondary cell therapies, including lymphocyte boost through a donor lymphocyte infusion, or even a repeat transplant. And again, at MD Anderson in the pediatrics department, we actually don't use triosulfan. For our myeloablative conditioning regimens, we use pretty strictly busulfan, again, paired generally with fludarabine in most cases, but there are some cases where you would consider using cyclophosphamide itself based off of toxicities that you may be concerned about. The researchers then, they reported 3-year survival rates and found that it was remarkable. In those patients that received whether a matched sibling donor, a matched unrelated donor, such as a MUD, or even a mismatched MUD, the overall survival rate reached nearly 90%. Moreover, again, they saw that patients less than 5-year-old who were transplanted, they had a much better outcome compared to those that were greater than 5 years old. Again, there's a caveat they actually do remark in the study that this 5-year-old rule was actually an arbitrary cutoff, and in fact should not be interpreted that those greater than 5 years of age have missed their mark. But again, the point remains, transplant early using a MAC regimen is associated with the best outcomes. And lastly, despite a transplant, these patients retain the risk of leukemia, lymphoma, and myelodysplastic syndrome, and so they do require close surveillance. And so this is something to keep in mind. And also, looking at the GVHD rate, severe, GVHD, which we consider as grade 3 to 4 acute GVHD, was only 6.6%, and extensive, moderate, chronic GVHD was remarkably very low at 2.1%. So Again, these patients do very well with a stem cell transplant, with close monitoring for GVHD, close monitoring for um, infection, as well as monitoring for just a sequela of Wiskott-Aldrich with the leukemia lymphoma that are generally not that are not cured with a transplant itself. Lastly, I'm going to go over chronic granulomatous disease, which actually, to my surprise, is actually one of the most common immunodeficiencies in Pakistan. And it is generally an X-linked disorder associated with mutations in the NADPH complex, leading to faulty phagocyte killing. Generally, the presentation is associated with staph infections, aspergillus, and nocardia as well. And these infections can be seen in your major organs, your lungs, your skin, your liver, and your lymph nodes. These granulomas form in the GI-GU tracts. They can cause obstruction, especially in the GI tract, and they can also impact the lungs as well, again, leading to severe respiratory symptoms and obstructions in those alveoli and bronchioles. For diagnosis, we generally rely on the dihydroamine test, or DHR for short, such a difficult word to say. It is a flow cytometry-based testing, and it looks at the reactive oxygen species production, by measuring the fluorescence change in cells that have been labeled with DHR. Another test, the nitro-blue tetrazolium test, it is an older test where you look at cells changing color in response to reactive oxygen species production. However, it's less commonly used nowadays. In terms of the treatment of chronic granulomatous disease, unlike SCID, generally these patients can be managed for a period of time with conservative treatment that includes strict hygienic controls, and adherence to antibiotic prophylaxis against bacteria and fungi, and usually that includes Bactrim as well as azole fungal medication such as itraconazole, posaconazole, and fluconazole. But as you can imagine, compliance is difficult in children and adolescents. And for the majority of patients, despite even good compliance, you can have the occurrence of recurrent or persistent infections, autoinflammation, and failure to thrive, which generally remain lifelong challenges. They contribute to the morbidity, they contribute to the mortality. And so you have this option of a stem cell transplant, again, in the face of having a maximum donor that can provide cure for these patients and really reduce the risk of their mortality and morbidity. There was a study published in Blood very recently in 2020, and they looked at patients who were transplanted with a myeloablative conditioning, or MAC. And what they saw was that the overall survival rate, again, was great. At 3 years post-transplant, it was a bit over 85%. GVHD rates were remarkably low. They were, significantly low and did not contribute significantly to the mortality and the morbidity. And again, I just want to emphasize the pattern is similar to SCID and Wiskott-Aldrich, that the earlier that patients are transplanted, they did lead to better outcomes. In this study itself, the median age was about 7 years old. And when they looked at older patients, especially those that were greater than 18 years of age, they found that overall survival was significantly low. It was 76%, again, compared to almost 86% or a little over 85% in patients that were younger. The other thing is they did look at a busulfan-based conditioning regimen with either fludarabine or in combination with cyclophosphamide. And they found that whether you added cyclophos with bu or you did fludarabine with busulfan, that did not impact the outcomes of these patients. So in summary, transplant for certain immunodeficiencies, again, SCID is an absolute. Wiskott-Aldrich and chronic granulomatous disease, it's a good option. It's a better option, I would like to say, when it's performed at a younger age. Matched sibling donors are available, but again, I think as these studies show, it's not a limitation. Mismatched unrelated donors or mismatched related donors are a possibility, and in certain instances, depending on the institution, umbilical cord blood transplantation is a possibility as well. There is a requirement that post transplant that there should be an adequate GVHD prophylaxis. What I mean by that is, yes, these patients are either on tacrolimus or cyclosporin, but these levels should be followed closely. There should be a strict adherence. Patients should be compliant. They should not be contributing to end organ dysfunction, especially in the cases of tacro and cyclosporin. And lastly, in patients that we're trying to prevent GVHD with these immunosuppressive agents, there is a need for great compliance, I would say, with antimicrobials for the duration of immunosuppression, and in some cases even past that mark, especially for viral prophylaxis. Again, the goal is to cure these patients, to take away a disease, but what we would like to avoid, which we always say here at MD Anderson, is we don't want to give them another disease. And that can be GVHD, either acute or chronic, or an infection. So it's definitely something to keep in mind, a discussion to have with patients, that transplant is a very tenuous process, but it doesn't end when engraftment occurs. There is a need for medication that can last 6 months, that can last 1 month, again, based off of the conditioning regimen used, based off of the donor source used, but also based off of the clinical status of the patient themselves. I strongly encourage people to read some of the studies that I referenced. They were very concise. They gave great information, and I think they were done very well. But I want to thank you so much. I really appreciated the opportunity to present, and I hope you guys were able to learn something on my behalf. Thank you so much.
Thank you very much, Dr. Itriza. The last speaker for this session will be Dr. Lawrence Faulkner. Dr. Lawrence is working as a pediatric hemoncologist and BMT physician at Cure to Children Foundation, or C2C. C2C was launched in 2007 by a group of parents who lost their children to cancer in collaboration with Dr. Lawrence. C2C is based in Italy but works globally. Dr. Lawrence will discuss the role of haplostem cell transplant in beta thalassemia major, LMIC perspective.
This is Lawrence Faulkner. I'm a pediatric hematologist-oncologist, and I'm affiliated with the Cure to Children Foundation, with the Sankalp India Foundation, DKMS Germany, and I also chair the outreach subcommittee of the Pediatric Disease Working Party of the European Bone Marrow Transplant Group. I have nothing to disclose, and in this presentation I will be talking about alternative donor transplantation for severe thalassemia syndromes. By severe thalassemia syndromes, I'm sort of clumping together transfusion-dependent thalassemia and what was called thalassemia intermedia, non-transfusion dependent thalassemia that cannot keep a hemoglobin of at least 8, which is known to have a severe clinical phenotype. I will be talking about the experience of the Sankalp Cure to Children network on 65 patients with severe thalassemia transplanted from haploidentical donors with the post-transplant cyclophosphamide approach directly in a middle-income country setting, primarily in India. And then I will also give a brief overview of donor-specific antibody positivity in multiply transfused patients with non-leukodepleted blood products, which may be relevant to, again, many centers in middle-income countries that may not regularly have access to leukodepletion. This is a report on the average survival of thalassemics in India. Was published in Blood Advances in 2020 from the Sankalp India Foundation experience. And you can see that in India, in spite of having 3 most patients having free access to transfusion and also chelation therapy. And the median survival is 25 years. So in the middle income country, thalassemia, of course, is a very severe disease with a significantly shortened life expectancy. And this is actually also true in high-income countries. In the UK, even though life expectancy is longer, still 80% of patients reach 45 years of age, but most of them will have one or more significant comorbidities. So even in high-income countries, as far as we know, thalassemia, even though things may improve, of course, with better supportive care, but is still a severe disease. But of course, in middle-income countries, thalassemia is associated, as I said, with substantially shortened life expectancy. We also know that transplantation has been done for many decades, and this paper from the Italian experience on a fair number of patients followed for over 20 years post-transplant. We know that transplant can restore a normal health-related quality of life, employment status, and birth rate similar to general population. Now, this was a study done in Sardinia where the birth rate is low. We know that this was BUSI-based regimen. Of course, we know that BUSI can cause infertility and delayed puberty in girls. It was also pointed out that healthy quality of life will still be effective in the patients that develop extensive chronic GVHD. It is influenced by age and BMT. For example, none of the trans children that was transplanted beyond age 15 years had preserved fertility. And of course, it depends also on comorbidity at the time of transplant. So, but I think it's fair to say that if a child is transplanted early, he is likely to enjoy a restoration of a normal health quality of life with a question mark on fertility. And in girls, we also have to consider that they may go into spontaneous puberty, but they could have precocious menopause. And so this should be part of this sort of counseling of transplant and also of the follow-up strategies. This is data from actually children transplanted in Pakistan. And because many children with thalassemia in Pakistan do not get regular access to transfusion, of course, transplant may also have the potential to restore a better linear growth, because those after transplant they have a more stable hemoglobin. But so there's no evidence, however, that transplantation per se will affect growth or intellectual capacity. This is a summary of the main publications on transplantation for thalassemia for patients lacking a matched family donor. So it's comparing matched unrelated grafts to partially matched related grafts or identical grafts. And you can see that the numbers are not very big, but there is really no strong evidence that much unrelated grafts do much better than haploidentical grafts. There are some experience with one published on blood advances on alpha beta depletion, and most of the others are on with the use of post-transplant cyclophosphamide. But you can see that there is, in terms of transplant-related mortality, thalassemia-free survival, and also graft versus host disease. There are no major differences. There may be a suggestion that maybe unrelated transplantation may be associated with higher incidence of graft versus host disease, while haploidentical may have more rejection. But there is presently there is no strong evidence, and one is much better than the other. So this is our experience from the Sankalp to Children Network in India. We have across 3 institutions in Jaipur, Ahmedabad, and Bangalore. And we have done 65 patients since April 2023, a median age of 8.6 years, ranging from 3.6 to 17.5. And all patients had donor-specific antibodies less than 2,000. We'll talk about this. And overall, the survival was 82%, with a disease-free survival of 76%, rejection 15%, and transplant-related mortality 18%, which of course are not very good results. But you can see that, first of all, the age had a significant impact. Of course, numbers are small, but patients older than 12 did seem to be doing less well than patients younger than 12. So younger patients may be better candidates, of course, as we know, for haploidentical transplantation. The other thing that I wanted to point out, there are 3 cases in 65 with moderate to severe graft versus host disease at 5-month median follow-up. So we may have more graft versus host disease. You cannot tell right now, the follow-up is short. But the cost for transplant was, for a haploidentical transplant, of course, these are all done with the post-transplant cyclophosphamide, was around $17,000. This is the protocol we employed. The protocol is essentially based on ATG, fludarabine, busulfan, and cyclophosphamide, 100 milligram per kilo before and 100 milligram after transplantation. We used peripheral blood stem cells because we were more worried about rejection than graft versus host disease. And then we also give 2 cycles, 1 month apart, before the transplant of high-dose fludarabine and dexamethasone. This was borrowed by the protocol used in Thailand. And of course, every patient gets an autologous backup before starting conditioning. The other thing I wanted to point out, we give rituximab 1 dose before transplant, and we combine methotrexate on day +1, 3, and 6 together, of course, with post-transplant cyclophosphamide and cyclosporine as GVHD rejection prevention. I already mentioned about the rejection rates, and these are other complications that we see. So, of course, CMV reactivation is quite frequent. Hemorrhagic cystitis is not very frequent and it's manageable most of the time. Also, veno-occlusive disease is not very frequent, but we lost 1 child from veno-occlusive disease. Same thing for transplant-associated thrombotic microangiopathy, and also in invasive fungal disease is actually quite rare. Most of these patients were done in HEPA filter and positive pressure rooms. Let's talk about the issue of donor-specific antibodies. Here I summarize briefly the recent guidelines that came out on the Journal of the American Society of Transplantation and Cellular Therapy this year. And so essentially, if DSA had non-specific antibodies, and this refers to the Luminex test, that the so-called C1b antigen test, is less than 2,000, no treatment may be required. And actually, was our cutoff to do the transplant. So we did not proceed to transplant in any patient that had more than 2,000 mean fluorescent intensity on Luminex testing. And if the donor-specific antibody level is very high, more than 20,000, essentially this would be a very high risk of rejection. And despite current therapies, for intermediate positivities, the sensitization therapy can be effective. Rituximab intravenous immunoglobulin may be sufficient for patients with lower donor-specific antibodies levels and negative C1q or flow cytometry cross-match. And for other patients, you may also need to employ plasma exchange and monitor donor-specific antibody levels before and after transplant could be important to guide preemptive treatment if the levels are persistently high after stem cell infusion. This is our experience on 381 patients with severe thalassemia who received non-leukodepleted blood products in terms of class 1 and class 2 positivity. You see that 2/3 of the patients actually are not DSA positive in spite of not receiving leukodepleted products. And then we have a small percentage of patients that have high DSA positivity. It's very unusual to have DSA positivity. We only had one patient, I believe, with more than 20,000. And the other thing is, though numbers are small, but there is a suggestion that, and I guess this is intuitive, that DSA positivity will increase the chance of having significant DSA positivity, in other words, more than 2,000, increases with age. And this may also contribute to increase the risk of rejection for older patients with thalassemia undergoing haploidentical transplantation. But as I said, we have not done actually patients with more than 2,000 mean fluorescent intensity on Luminex testing. So, in conclusion, young patients with thalassemia lacking a match-related donor may enjoy fair outcomes. As I shown in our experience, actually, they're transplanted before age 12. They can have, I would say, a fair statement is 80%, 85% disease-free survival with relatively low rates of moderate to severe chronic graft-versus disease. That is to say, most of these patients go back to a normal health quality of life, as I said, with a question mark on fertility. And DSA appropriate, with the DSA appropriate haploidentical hematopoietic cell transplantation in experienced centers with widely applicable and relatively inexpensive approaches. I mentioned that in our center, can do a haploidentical transplant, and this covers the whole year after transplant for $17,000 directly in a middle-income country setting. No prospective studies have established the superiority of marrow-related donor transplant versus haploidentical in severe thalassemia syndrome. In case of high DSA positivity for all partially matched family donors, then a match-unrelated donor or even a partially match-unrelated donor, but DSA appropriate, may be a reasonable and preferable alternative. Marrow-related donor transplant may be associated with high risk of graft-versus disease, while AFBMT may have higher rejection risk compared to unrelated donor transplant. And of course, it would be desirable to do randomized control studies that probably can only be performed given the numbers in Southeast Asia. And of course, these trials should also compare cost. And with this, I have done, and I thank you all for your attention. Thank you.
Thank you very much, Dr. Lawrence, for a very informative talk. The House, ladies and gentlemen, is open for question, answers, comments, and discussion, please.
So I have a question for Dr. Lawrence. So for those patients who have a DSA negative, that is 2000 MFI, do you still use that extensive protocol of day minus 68 incorporating Fludera Dexa 2 blocks and also adding Retux at the end of the conditioning? And I think that would be so much of immune ablation, increasing the risk of CMV reactivation and infections after transplant. So what is your take on that?
Sorry, ma'am, Dr. Lawrence is not available at the moment, so he will not be able to answer this question. Yes, ma'am, he's available.
Can I answer that partially? Actually, the haplo transplant protocol that Dr. Lawrence has shared, we had used it for a couple, but the DSA has nothing to do with this flux and fludarabine and Dexa, which is given for 5 days monthly for 2 months before the transplant, and that is basically to decrease your autoantibodies or anything. So this is for the risk of rejection. For CMV again is more T suppression and reactivation. So that really rituximab doesn't do anything for your T function, right? And again, rituximab is also given as an attempt for decreasing your rejection rates. So this is independent of your DSA. If you have a DSA positive, then you have to go towards the decreasing the DSA, which is another either plasmapheresis with IVIG with rituximab. That's a different protocol. This is desensitization protocol is totally different than this. This is not a desensitization protocol. This is, I mean, our treatment related mortality wasn't that bad, but we did have bad outcomes in terms of rejection. So even with all this, there was rejection and bad GVHD. So our experience of using haploidentical for benign conditions was not that great. So for now, we are not doing any haplos for benign conditions because again, reactivation of CMV was very high, and controlling that sometimes is a challenge. GVHD was bad, and again, the options of us treating GVHD is very limited for our settings. We have very little resources with ruxolitinib coming in, but again, that's expensive. So these things are an issue that we had challenges of, and patients and families had challenges of. We are using the standard protocol, which I think, anything above 1000. And that also makes a difference as to which one it is, right? More than 1000, yeah. Yeah, so that's standard.
So I have another question for Dr. Mohammed Ali regarding transplant and MPS1 HERLA. So do you use enzyme therapy as a bridging to transplant, number one, and what is your experience of haplotransplant in HERLA? Since we know that we can get MSD in around 30% of the cases, we don't have much, so haplo remains an option for these kind of patients. So I have 2 patients of HERLA who are haplo, but I want to know your experience regarding this.
So yeah, it's a good question. So we do use enzyme replacement therapy around transplant. So before transplant, we give at least for a few months. The idea is basically to improve organ function prior to taking the transplant, because that will help the tolerance of the transplant procedure for these patients. And also we use enzyme replacement for at least 3 months after transplant, just to help again to improve organ function. So we don't, at the moment, offer haplotransplant for patients with Hurler syndrome, so I cannot share any experience because most of the time, if you don't have a matched sibling, then usually we go to registry to find a cord blood or a matched and unrelated donor. But I do see, I think, a situation like in Pakistan where you cannot get cord blood easily or cannot get at all or unrelated donor, then I think your best other options are either haplo sibling or haplo parents. So you just need to think how to condition and how to prevent graft versus host disease. And then I think your donor will likely be a carrier donor. So if you have the option of haplo non-carrier sibling, I think that will be better than haplo parents.
Thank you very much, Dr. Ali.
May I have a question, please? So,
Thank you very much. It was a very exciting session. Thank you very much, all the speakers, Professor Tariq Ghafoor, Professor Faulkner, Dr. Ali, and Dr. Itriza. So it is very exciting to see the transplant outcomes and immunodeficiencies and metabolic disorders. What I could get from your presentations is the earlier the diagnosis, earlier the transplant, better it is. So knowing about our country, that is low and middle income country with limited facilities, what you people think is the cause of how can we avoid delay in the diagnosis? Because if you don't have any affected child in the family, so do you think it's the clinical experience of pediatrician or the availability of the investigations? How could we shorten this time period to diagnosis? Once they reach the tertiary care center or a transplant center, obviously the search for donor and transplant is earlier, but the delay has already been done before the patient reaches the tertiary care center. So what do you think? It's the clinical experience, clinical suspicion should take the lead, or do you think that there are lack of resources for the investigations like THR or all the genetic testing for these disorders? Thank you.
Yeah, I would take this question in terms of metabolic diseases. In the absence of newborn screening, I think the dilemma is almost same everywhere, even in Canada. So we have a few patients diagnosed late for Hurler syndrome, and also patients with the cerebral form of ALD as well. And the index cases usually, unfortunately, the first child in the family, they suffer due to delayed diagnosis. The advantage of the Hurler syndrome, you can probably diagnose early if the clinician has some experience to see a child with Hurler syndrome. So based on the phenotype or physical features of the Hurler syndrome. And we usually, all the book says like probably don't take them to transplant if they are 2 years and older, but because their disease progression is not as fast compared to the leukodystrophies, we still offer a transplant if they have reasonable organ function. So I have two patients, 3.5-year-old at the time of transplant, and one is now 5-year post-transplant, reasonably well, have good quality of life, going to school. So the cerebral ALD patient is a challenging one because if they are diagnosed late, then it's better not to take them to transplant because their outcome will not change with transplant. So after a year after transplant, they will be wheelchair bound, they will be spastic, they have lost all their neurological function. It's better not to do the transplant and ask parents to probably use the cherishable time they may have for a year or so with that child. So because transplant will not do anything good for late diagnosis of ALD patients. It's a clinical experience. So
wonderful talks by Dr. Ali, Dr. Itriza, Professor Tariq Ghafoor, and Loris Faulkner. I have a question from Professor Tariq Ghafoor. Sir, when we treat high risk ALL, especially TALL, we give very extensive chemotherapy, whether this is PSP protocol, UKLL, or COG. 8 months of extensive chemotherapy followed by 3 years of maintenance. But this is very difficult to maintain the infection-free environment for this prolonged time, means for 8 months of chemotherapy. But on the other hand, we can manage transplants with 1 or 2 months in controlled environment. Don't you think that in TALL we should offer the upfront transplant when patient is in remission as compared to prolonged protocol? If the mass sibling donor is available?
No, because the transplant-related complications and other problems are, I think, much more than the maintenance chemotherapy. And I have not gone through any study which mentioned that the all pediatric TLL should be transplanted. TLL, pediatric TLL has almost same survival as the BALL. There may be 1 to 2% difference, but the survival in our series was also very good. So considering the toxicity and other problems of the transplant, I don't think I can recommend that the TLL should be treated with a transplant. Definitely the main, as I mentioned in my talk as well, the early the diagnosis and earlier you start the treatment has the best impact on the survival of leukemia in pediatrics. Just a comment among the transplant in metabolic disorders. You should be aiming to transplant not with a carrier. I had a family who were transplanted, I don't remember the exact disease, but some metabolic disorder. They transplant two children in India, and with the carriers, and they were having the chimerism was almost 50% or something. So it's basically useless exercise. So try to avoid the transplant with the carrier in the metabolic disorders. And the conditioning, as I mentioned, the busulfan and myeloablative should be done for the metabolic disorders.
Thank you very much, Sir Tariq Ghafoor. I know you must be having a lot of questions, but due to shortage of time, we'll be summing up the session. So I would like to thank you, all the speakers, worthy chair, worthy panelists, and all the active participants. So this is the end of session 4. Thank you very much.